So this is a great question for a couple of reasons. I think, first of all, it underscores the distinction between a genetic diagnosis and a clinical diagnosis, right? So you could diagnose fever by testing somebody genetically and seeing if they had one of the recognized genes which cause fever, or we can make the diagnosis clinically because it has a very characteristic appearance. So if we, see a child or patient and they have the classic manifestations, particularly if we then examine, the parents and one of them has the manifestations as well, it's pretty clear that they have the clinical diagnosis. So that's kind of the two different ways to do it. Interestingly, of those who have a clinical diagnosis of fever, when you test them genetically, only about half of them end up coming back positive for one of the known mutations of fever. So if folks are negative, it doesn't mean that they don't have fever. It just means that they don't have one of the genes that has been recognized. For example, it may be that it's not a single gene that causes fever in some patients. It may be the combined action of a couple of genes. And those genes that are acting together have not yet been identified and things of that nature. So apart from that general comment, speaking about the special case of a child, there's a significant amount of overlap between fever and retinopathy of prematurity. And I would say that the diagnosis of fever in a premature infant generally comes about clinically, not genetically, clinically in one of two ways. Number one, if the child has retinal findings that in spite of the child being premature, these findings are atypical for retinopathy of prematurity and more typical of fever. So there are certain ways that fever can look with regard to the configurations of the detachment and so on and so forth that are more typical of fever than of ROP. And then the other way is a child who has retinopathy of prematurity that has an unusually aggressive course that doesn't respond to the conventional treatment approaches that typically result in a good outcome. So unusually aggressive retinopathy of prematurity is another thing that signals to us that a child may have a fever gene in addition to being premature, which is, throwing gasoline on a fire with regard to the rate of progression of the underlying retinopathy of prematurity type changes. Dr. Drenser, anything that you would like to add?
I think that summarizes it very well. I think it's very important, especially when dealing with a premature infant, that if we have the suspicion of fever, the genetics are helpful when they're positive, but they're not determining the end result of the clinical diagnosis when they're negative. And really, it's helping us to better manage that child long term, because if we suspect that there's an atypical feature, which may be more in line with fever, it may prompt more lifelong examinations at a more frequent interval than we would otherwise also be doing for just a retinopathy of prematurity situation.
So we consider, fever is a lifelong disease, and we follow folks with fever typically at least twice a year, generally, for life. And the reason is that some of the features are present and even dramatically present in infancy. Other features are more smolderingly progressive. They progress little by little over the course of time. And the three major features of fever in the back of the eye are traction on the retina due to scar tissue, leakage from abnormal blood vessels, and loss of the very smallest and finest blood vessels, which are known as capillaries. Much like in a plant where it's the fine hair-like roots that do all of the work, so in the body, the capillaries are really the point where oxygen is exchanged. And so in fever, the capillaries can gradually be pruned as an affected individual grows. And that can have consequences on vision, and that's potentially amenable, at least with current technologies, to treatment with laser and hopefully, with other approaches in the future. So those are the reasons that we follow folks with fever lifelong. Scar tissue traction and the traction attachment that can occur as a consequence of it, leakage and capillary dropout. Kim, anything to add?
No, those are the salient features, and they're hard to predict. I mean, one of the things that we've learned with doing the genetics and trying to track some of the characteristics that we see with children is trying to be able to better predict so that we can maybe identify somebody who only needs to be seen twice a year as opposed to every 2 to 3 months. But essentially, we're looking for those characteristic changes to indicate how aggressively we have to intervene and how often we need to see the patient. So this is a very common question, both the COVID vaccine and its how it impacts eyes, but also just getting infection if you happen to become positive and ill with COVID. There's been no evidence or even theoretical indication that either contracting COVID or getting the COVID vaccination has any impact on the eye, and more specifically on the retina, even if the eye is at risk from something like fever or other retinopathies. There doesn't seem to be any overlap or concern in regards to following normal recommendations to keep the child safe.
All right, so I would just add, so therefore there's no reason out of concern for worsening fever to avoid your child getting a vaccine, or yourself getting a vaccine if you're an adolescent or an adult with fever. Yeah, so the challenge with, so retinal folds are one of the more common, unique fever features. There aren't a lot of diseases that cause the folds that have the appearance that the eyes do when these folds are present due to fever. And I think, the upside is that eyes with these folds tend to be very stable over the course of a child's life. So they do have a fairly significant impact on vision. But in spite of the sort of how dramatically these folds alter the anatomy, the children often end up seeing better than one might imagine, which is kind of a recurrent theme for sort of anatomic distortion in a child's eye. Children are often able to make more of the anatomy that they have than one might imagine. The downside is that we really haven't got away with current technologies to unfold them in a way that has an acceptable risk profile. I mean, so it wouldn't be accurate for me to say, well, I can't go in and unfold it. I can, or Dr. Drenser can, but we have to cut the retina and do a variety of other things that actually make the situation are likely to make this, the treatment would be worse than the underlying disease, if you would. So likely stable over life, and with current technologies anyway, not really repairable.
So there are a number of therapies that are being looked at, and one of the ones that is very close to us is because we've been working on this for a number of years, which is a drug called Norigen, and it is a mimetic of human neuron. And what we found is that being able to add that into eyes with retinopathy similar to what we see with fever is able to rescue the retinal vasculature and provide regrowth of capillaries, and also prevent the leakage that we see in these capillaries as well. And this has been done in animal models. We have not used it in humans yet, but that's probably, in my opinion, the most exciting therapy. There are a couple other groups working on therapies that are of a similar fashion and trying to work at ischemia. They aren't specific for fever. So this is the first one that's specifically looking at fever as the target eye disease to try to treat. In regards to where we are with the development of Norogen as a therapeutic for fever, we are currently in what are called the preclinical phases. So we are doing all of the manufacturing to get it up to the quality that it needs to be used in a human, and doing all of the supporting documentation, toxicity studies, animal studies. The hope is that we will be able to file with the FDA to move forward with clinical trials within the next couple of years.
Folks who aren't familiar with clinical trials, that Dr. Drenser is talking about entering phase 1 clinical trials. Clinical trials have 3 phases. Phase 1 is the safety phase. Phase 2 is when you look for what we call biological signal, basically to see if it works. And then typically in phase 3, you'll do a larger number of patients and check for both safety in a larger population and try to refine the specific dose. So if, for example, to play out the rest of the hand, if I may, Norogen were to make it into a phase 1 clinical trial within a year or 2, it's typically then another 3 to 5 years before it's available on the shelf, if you will, for the doctor to use it. So we're probably talking about 3 years would be very, very optimistic, more like on the order of 5 years or so before Norogen will be commercially available. Kim, do you agree?
Totally agree. I think that's a very realistic timeline.
So as regards the issue of financially supporting the research initiative, monies that are donated to the Pediatric Retina Research Foundation really go to our 2 major mission initiatives. One is to support the community of the patients and their families who have the pediatric retinal diseases that are so in our universe, if you will. And the other is to support the research proper. So really the best way to support both the community and the research is to donate to the foundation.
Well, so as the goal with Norogen is to really address the underlying problem, the primary problem with fever, which is the lack of complete vascularization of the retina and the loss of capillaries. So it's really looking at the vascular issue. It has the added benefit of having a neuronal regenerative capability potentially because of the way that capillaries and neurons grow together. So that is on the forefront of something that would actively change the current status of the retina in making it healthier and less fever-like, for lack of a better term. Other treatments are still otherwise really geared more towards controlling the sequela of having incomplete vascularization and leaky vascularization. So controlling exudation, treating the avascular retina, surgically intervening when you have scar tissue or tractional changes. And those really continue to be the mainstay of treatments at this point.
I think that's a great answer, Kim. I think it's important, though, as a point of reference here, when we talk about treating fever, the paradigm isn't like, say, treating pneumonia, where you have someone who was normal before they had the pneumonia, then they had the infection, then you treat them, and they go back to being normal. That's not really where we are, where our opportunities are in the arc of the disease, if you will. When someone has fever, or for that matter, this is a conversation that applies to Norrie disease or Coast disease or some of the other things that we treat. Many of them have their onset in terms of when they start to impact the retina, in utero, during formation of the fetus. So when the child is born, we're sort of handed a certain sort of set of findings, if you will. And our charge as physicians is to try to normalize those features in as much as we can, whether it's medically or surgically. So rendering, and where I'm going with that is, where we encounter questions about cure. So cure with currently available therapies and the current paradigms isn't really possible, because you'd have to have the opportunity to have, a normal substrate, or a normal sort of set of anatomic circumstances that you could bring the eye back to, like my pneumonia example. And we never get that with the kids who have the pediatric retinal conditions that we tend to. So we're relegated to try to, our current, sort of treatment initiatives are all geared towards trying to make things as normal as possible, given what, given what we are handed when a child is born with one of these conditions.
So in my opinion, genetic testing plays a variety of roles. At this point, genetic testing is not going to be used for a cure. And so we'll start with that, because that tends to come up a lot, is how do we cure this? Fever is complex because multiple genes are involved. And in order to cure a genetic disorder, you really need to be able to replace the affected gene. And so when you have, the more and more genes you have that are involved, the harder it is to come up with a true genetic cure for it, because it becomes more and more complicated. So I don't necessarily think that genetic testing is essentially for a cure at this point, or for gene therapy, but I do think that genetic testing is very, very important for better understanding the variety that we see in how the eye behaves, how it behaves over time. So we do learn more about understanding, the different genes and what their role is in the health of the retina. It also, a negative genetic test does not mean that you don't have fever, because it's a clinical diagnosis, but it does help support a fever diagnosis, particularly if there are other factors that may be confounding the diagnosis. And I also think that it's very, very important from a family planning standpoint. Oftentimes people are surprised that they have a fever mutation in the family. They can be sporadic, so it may just be that that child or that patient was the only affected individual within the family, but that tends to be less common. So this will oftentimes prompt multiple family members to get tested. And then more than often than not, we find that we identify a number of patients in the family that didn't realize they have fever. They come in, they get their exams. Some of them actually have enough change in their retinas that they do warrant some sort of treatment or intervention. And furthermore, I think that it's important for future generations. As we do hope to be able to get better with interventions and treatments, and eventually maybe even gene therapies for cures, early diagnosis is going to be key, and maybe even in the early phases of pregnancy for family planning and medical planning. So I think that genetics is more than just saying, aha, we have this and we know how to treat it. And hopefully that's what it'll eventually lead to as well. But at this point, I think it still has a robust place in patient management.
Yeah, I can think of two other things, really. So if we're going to, so we examine family members, whether or not the affected individual, the child, test positive genetically. When we don't have a positive genetic test, though, we're relegated to the clinical examination as the only way that we can diagnose a family member, right? Whereas if we have a positive genetic hit, then even if someone lives far away, we can make a genetic diagnosis. We can make a diagnosis on genetics alone as to whether or not they're a carrier. But then to get back to the point that we started off the whole conversation with here, to assess the severity of the disease and whether or not they need treatment, to Dr. Drenser's point, will require a clinical exam. But to say whether or not they just carry the gene and therefore have the fever gene or one of the fever genes or several, genetic testing is useful in that regard. And then I think from a theoretical perspective, going forward, as we develop therapies, there are some genes that we will be able to treat, first, second, third, fourth, and fifth, have to do with a variety of technical factors. And knowing which specific one you have, will allow us to identify what people would be sort of eligible for or amenable to the therapies as they become available.
So I would start this by saying that I think that it's very important to understand the difference between Norrie's disease and X-linked fever, because they affect the same gene, but they have different implications, especially long-term for that affected child. Traditionally and classically, Norrie's disease is the triad of blindness, deafness, and cognitive decline. Whereas fever really typically is just an eye only affected eye disease. So if we start with Norrie's disease, it's important to understand that as of now, there really isn't a cure, although I could make the argument that if you're going to look at a gene replacement therapy, it's an ideal candidate because we know what the gene is. And so you're not looking at multiple genes, you're looking at a single gene replacement. The real complexity with a genetic treatment for Norrie's disease is that it would have to be done very, very early in development, probably potentially even before the fertilized egg implants. So you may be looking at an in vitro fertilization type of situation, or very shortly after implantation with an umbilical cord gene transfer early on. So there are some complexities with that, but it is a single gene, which is one of the ideal things. And it's a very small gene, which actually also makes it very amenable to gene therapy as well. So it does have some potential for that long term. As far as I'm aware, nobody's actually working on that at this point. As far as current treatments for Norrie's disease, so if we look at Norrie's disease, we know that the first noticeable change is with the eyes. The eyes have very severe detachments, generally at birth. So these can be picked, is usually the first sign that there may be a problem. And we also know that the best intervention for Norrie's disease is early surgery. So intervening and oftentimes removing the lens and releasing the traction on the retina as early as possible gives them the best possible results to maintain some vision, and albeit it tends to be very low vision, ambulatory vision, circadian rhythm vision, but that's the best time. Not to kind of jump off of the eye topic, but again, going back to the classic triad of deafness, I think it's also very important to, and I didn't even realize this until, maybe a decade ago, really understanding the timing, that the Norrin gene is important for the development of the retina and the eye. But the ear actually develops without the Norrin gene. It uses other signals, other pathways to activate that. And so babies with Norrie's disease are actually born with normal hearing, and they'll pass their hearing test in the hospital. So it's very important that if it's suspected and they have any sort of genetic confirmation, that they get a hearing test usually when they're about a year old, again, to identify any loss of hearing, which usually starts to manifest around a year old, and they probably need an annual hearing test to follow that. And then finally, the cognitive changes that occur in Norrie's disease is because the brain also requires Norrin, and the Norrin gene product for normal maintenance of the brain. And similar to the ear, there are other proteins which can take the place of norrin, which is why oftentimes the cognitive delay is a late onset feature, which is makes it a very, very difficult syndrome to manage, because everything, you think you have one thing under control and then something else starts to unravel. Similar to why the eye for Norrie's disease is a potential for gene therapy, hearing is as well. And because they're born with normal hearing, you have a less complex potential to rescue hearing in these children with intervention. Now, as I mentioned, the reason I like to talk about Norrie's disease distinctly from X-linked fever is because children with X-linked fever can still have a spectrum of eye problems, from very mild to very severe. The most mild can be managed just with laser treatment, and they do very, very well. And in fact, the studies that we've looked at have shown that if they fall into that group, they oftentimes are stable with just a single intervention of laser. You can have more severe disease that may require surgical intervention as well, although they tend to have less exudation. So the chronic and repetitive recurrent exudation doesn't seem to be as much of a problem. It tends to be more tractional and scar tissue in nature if it's severe disease, but surgery is still a reasonable intervention with varying degrees of success. And the difference between calling something X-linked fever versus Norrie's disease is really how severely affected the norrin gene itself is. If it has any ability to function or not. If it has some ability to function, the children with X-linked fever will not display hearing loss, and they won't display cognitive decline. So I think those are the big distinctive factors in managing and understanding the prognosis for children.
Oh, yeah, so that's a question, so fortunately, we don't have, increasingly, our neonatology colleagues are getting a lot better at managing children who were born prematurely, and ROP's incidence has significantly declined. So we don't certainly see as much of it as we used to, but we will occasionally get the question about what is there to do for a child who's had total vision loss. And at the moment, there's really there's no mainstream therapy that will restore that vision loss. And there's a couple of different reasons for that. The eye sort of receives the visual information, and when the retinal anatomy is abnormal enough, so-called stage 5 detachments, the eye is not going to receive that information. But also remember that happens to the child at a point in life where the visual system hasn't really developed yet. If you look at a child's hand, that hand is fully developed at birth. It needs to get bigger, but all the details are there. The visual system is nowhere near complete at birth and really continues to form over the next, at a minimum, 9 years. So when a child doesn't see from infancy, then the part of the brain that serves vision doesn't develop. So there are sort of two strikes, against that child with regard to vision. There are some technological approaches to using other senses as a surrogate for vision. This is outside of our wheelhouse, but there's some work being done using taste and the tongue as a surrogate for providing visually important information. And there's something known as echolation, which some children use to identify objects or hallways and things like that. So these are sort of surrogates for vision, but they're not really vision per se.
So Coates disease is, in my opinion, one of the more frustrating entities, in part because unlike fever, where maybe we don't know all the genes involved, we know a lot of the genes involved. We know the main pathways involved. We have an understanding of what's not going in the right direction and why, which gives us some ideas to how to try to manage it. Coats is frustrating because it's not a genetic disease. It's a unilateral eye disease, which always sounds strange when I talk to parents, is a good thing. It's isolated. It's not a syndrome. But it's also frustrating because we really don't know why it happens, when it happens, what triggers the event. We know that it happens as the fetus is developing and at some point while the eye is developing. And presumably there is something that goes awry in that one eye where the vessels take an abnormal course of growth. And how abnormal those vessels are affected really just determines the severity of Coats disease. So we're really left with, if you have a cold, we don't know where you got it or how you got it, but we're going to manage your symptoms. Coats to me is a lot like that. You know, we use all the tools we have to control the really exudation and scar tissue that you get from Coats disease with lasers and with injectable medicines. But we don't have a meaningful cure because we still don't even understand why it happens in the first place. And so until we have a better understanding of that, I think we're going to be a little bit in using the tools that we have. Now, as tools get better, you know, we'll add more tools. But to say that there's a targeted therapy for Coats alone, we're not there.
Yeah, so this is another good question. So first of all, patching is generally done by pediatric ophthalmologists, the doctors who take care of, crossed eyes or so-called strabismus. And the patching is done when one eye is not developing as well as the other in terms of vision development, because the brain will often play favorites and pick the eye that sees the best for development. So when one eye ends up being sort of the redheaded stepchild, from a developmental perspective, that we call that amblyopia. And again, pediatric ophthalmologists usually do that. Now, I will say, though, that pediatric ophthalmologists are usually doing that with eyes that, apart from the cross, the retina is entirely normal in both eyes. And so our population of children are different. The retina is not normal. And so there's a little bit of a sort of preconceived notion that if the anatomy of the retina is normal, it's kind of not worth doing the patching because, abnormal film means, abnormal picture. So you won't be able to get anything out of that eye is the notion. And by virtue of what we do, basically handling eyes with abnormal anatomy all the time, we've learned that sort of preconceived notion is incorrect, and that the children are usually able to make much more out of an abnormal, anatomically abnormal eye than one might ever imagine. And further to that point, to fix an eye surgically, particularly if the companion eye is more normal, and then not patch, the brain's going to turn that off because, again, it's going to play favorites. So you need to patch to get the most out of whatever surgical intervention you've done, when the anatomy is abnormal. So commonly, the degree of nearsighted, of amblyopia rather, or lazy eye is actually pretty profound. So another difference between our kids and kids with crossed eyes is you can often get the kid with crossed eyes, that weaker eye, back to normal or pretty close to it by patching. For our kids, once the difference is that much instead of that much, you're not going to bring this eye all the way back up to there. But by patching, you'll be able to take it from here, to there. And so you want that eye to be as good as possible, because we imagine that in the future, the better the eye sees, the more fertile soil it'll be for whatever technology comes along next. So all by way of saying that we'll start patching many times at 5 minutes a day, because when the child doesn't really see very well, they won't tolerate patching their good eye to make the weaker eye stronger for very much longer than that. If you increase by 5 minutes a week or so, little by little, you can get up to an hour. Once you're up to an hour, it's a lot easier to get 2 hours or 3 hours if you need them. So we have a philosophy of who is worth patching that is different than a general pediatric eye doctor, because our world is different. And so we'll often undertake educating them as to what we do and why. And we have sort of a more patient curve to get us to the amount of patching we want to get to that's appropriate for the child's circumstances.
The question regarding the CRX protein and its effect on Leber's congenital amaurosis actually addresses a much bigger question, which is that is an extremely rare mutation with a rare disease. And unfortunately, in any of these rare diseases, you're talking about very, very specialized treatment. And you can't get a universal treatment. So all of these are looking at some form of gene therapy or gene editing for the vast majority of treatments that are going to be meaningful. So rather than talking specifically about that particular gene and its role in LCA and where it stands in clinical trials, there is a great resource for people who want to know. It's clinicaltrials.gov. And I always encourage all of my patients and family members to every few months go ahead and peruse. It's very simple to use. It has a search entry site, and you can put in the gene and you can put in other variables, and it'll pull up any clinical trial in the United States. So it's a real quick way to keep yourself in the loop with what active clinical trials are. Most of these are not at the clinical trial phase. So for all of these rare diseases, looking at gene therapy or gene editing, gene therapy requires a known gene that is amenable to replacement, and not all mutations are. You have to be able to, because gene replacement doesn't eliminate the mutated gene, it just adds a normal gene. So there are some diseases that are not amenable to it. Autosomal dominant are very good types of diseases to have for gene therapy, because you don't have to get rid of the mutated gene. You just had to add a normal one. For most of the cases, the same thing with autosomal recessive. Autosomal recessive oftentimes can be corrected just by having a normal gene because it has two abnormal genes. But it doesn't work for everything. There are some gene size limitations. The most common vector is an AAV base, or a recombinant adeno-associated viral vector, but they can only take relatively small genes. So not all genes are good candidates. Some of the other viral vectors have issues. Adenovirus tends to create immunogenicity, so your body creates a response to it. So it can harbor much larger genes, but you don't have necessarily the cleanest technology with it. There are also some lentiviruses, which are somewhat promising as well, but again, are not universal cures. So there's a lot of complexity that goes into just trying to fix a gene. Newer technology, which people may have heard about, is something called gene editing, and this is CRISPR technology. It's very exciting. It's still very, very preliminary. Basically, what this is trying to do is be able to not add a normal gene, but actually cut out the mutated portion of the gene and splice in a piece with the normal sequence. And all of these different technologies are being evaluated for lots of different rare diseases in just genetic disorders, particularly when a gene has been identified. So I think that's probably the better answer to that. As it stands right now, there is nothing in active clinical trials.